Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anyone. Okay. How many of you can identify the specimen and how many of you understand which surgery it is? Okay. Do not fear. Okay. Do not fear. Just whatever comes into your mind first is usually the correct answer. So just write down whatever you feel, right? Again, lots of students I can see joining in. I'm very, very happy. Please join in, everybody who's there on the group, who's not inside the chat room. Please write down, just enter through that chat portal that has been given to you right now, and you'll be able to communicate with me, right? That's right. That's right. Very good. What do you think is the specimen? What does it look like? See, now let me tell you this trick about OSCE. All right. Sometimes you might be wrong. Sometimes what you're thinking might not be correct, right? Very simple thing is to just describe what you're seeing. What you're seeing right now is a specimen of a uterus with the cervix, probably a vaginal cuff along with it, and it's got irregular bilateral masses, most probably ovarian in origin, which have rugged outside irregular borders, query-papillary projections, solid areas, query-cystic areas. Just listen to what I'm saying, all right? I'll repeat it again. Query-cystic areas, most probably ovarian carcinoma. Okay, most probably that. CA ovary. Very good, excellent. So again, this is a specimen of a uterus with cervix, query with some part of vaginal vault, with bilateral adnexal masses. Now, I don't know whether we'll call it, is it right to call this right more than left? Okay, with irregular, ragged, jagged borders, query papillary projections, query solid plus cystic areas in the favor of CA ovary. All right, what do you think is this, guys? This thing which they have shown over here. What do you think is this? So whenever you do the ovarian carcinoma surgery, you always do this part as well. What is this? Yes, very good. Initially when I saw this picture, I was like, the picture is so, this doesn't look like omentum. Okay, it's looking something else. But then when I saw that what questions they've asked, they give you a hint, right? So yes, all of you have written it. You are all right. This is a TAH plus BSO plus omentectomy sample, and this adds on to our confidence level that this is, if this is omentum, which is most probably is. See, earlier it was looking like that morcellated fibroid, right? That is how it is so long, but it was not looking. Omentum is usually like a curtain, that long. It's not like this, but it's okay. Now we do understand that by you take out the specimen, it usually contracts, and that's how it's looking over here probably. So anyways, this is omentum, because usually when there is a CA ovary involved, you go for a TH, you go for a BSO, you go for a radical hysterectomy. Actually, you even go for a part of vaginal vault. You go for lymphadenectomy, but you also go for biopsies from all peritoneal deposits that you can see and pelvic deposits that you can see, and you go for omentectomy, which is very, very important, which they want to hear, which is why they've given you this particular look. All right. Name 2 tumor markers for this pathology, which is very evident in this picture. What will you answer, guys? So up till now, you were right. Now let's hear this thing. Name 2 tumor markers. Everybody knows one. Okay, the second one I want to hear. Which one do you want to give? Okay, some are saying CA, some are saying AFP. What else? What else? Something specific for carcinoma, something which is also utilized in some other tests, right? I don't know how many of you have seen my video on IOTA scoring, Roma, ROCA scoring. I don't know how many of you have seen that, in which I've tried to delineate these terms. I've tried to explain you what exactly is the meaning of IOTA. IOTA is done through ultrasound. What is Roma, ROCA? They're done through biochemical serum markers. And what is the latest scoring, guys? Can anybody say about the ovarian carcinoma, or let's say ovarian cyst? What is the latest scoring? Okay, some of you are answering right now. Yes, good. Very good. Sneha, Sanya, yes, correct. RMI, no, not that one. RMI scoring is separate. Yes, it's also very, very important. If you go through the RCOG guidelines, RMI scoring is the one, right? But the latest one is ORADs. I think I spoke with you regarding this couple of months back when I was doing, I think, ovarian carcinoma, yes. So ovarian cysts, now the latest is ORADs, in which the scoring is given in such a way that we can delineate whether this is a malignant lesion, borderline lesion, or a simple cyst, or a benign cyst. We wouldn't call it a simple cyst, but a benign cyst, right? So yes, I am so proud of all my students. This is the power of collective learning. Very good, very good. You're trying, and maybe you're right, maybe you're wrong, but you're all trying. That's excellent. So the answer which I would want to give as a postgraduate student will be a CA 125 with HE4, because HE4 now is being utilized in ROMA and ROCA tests, the serum biochemical tests, in which we try to delineate the ovarian malignancy, ovarian carcinoma. So we utilize HE4. Transferrin, transthyretin, I'll have to see, Neelam, all right? I'll have to see whether that is there or not, and whether it will be taken up in preference to CA 125 or HE4 or not. But yes, definitely HE4 I would like to include. And CA 125, everybody is expecting of you. But the second one, everybody wants to know. Let me tell you, when I was taking I took 2 sessions, right, on ovarian, I would say, ovarian masses. One were those benign masses, benign and malignant both, in the this adolescent and child age group. The ones in which I included the granulosa cell tumors, which includes the benign and malignant both. And then I included the ovarian cysts or ovarian masses in the adult group, in which I included the benign cysts along with the malignant transformation of going to ovarian carcinoma. In the adolescent age group or child age group, we spoke regarding the 3 important tumor markers which have to be done to delineate for any ovarian mass in that particular age. I think I did tell you about those important tumor markers, right? So that is where I had included this AFP was there, beta HCG was there. No, we do not include CA 125. We include these important tumor markers. We include AFP, LDH, we include beta HCG. All right. So these are important tumor markers which have to be done in any, this adolescent age group, because we are expecting granulosa. We are expecting basically the germ cell tumors. Correct. So I wouldn't want that thing to be spoken here. That is what I want to say. Correct. All right. Enumerate any 2 factors that will affect the prognosis of the disease. Now, when you're talking about ovarian carcinoma, what factors affect the prognosis of this disease? That is what I want to know. All right, let me hear this. Any 2 factors that affect the prognosis of this disease. What do we have here? Yes, stage of the disease, very important. Yes. Staging, grading, you can always say, right? So how far this disease is metastasized? What is this, grade of the tumor? Okay. So you have gradations as well. And what else? Okay. How much? Very important, very important. I think I have not included this in my answer, but very important point. How much residual disease have you left after the surgery? Because every time, whenever you have ovarian carcinoma, unlike vulval carcinoma or unlike cervical carcinoma, we go in for a surgery, right? In cervical carcinoma, after a particular stage, you do not go for surgery, right? You go in for a chemoradiotherapy. But for ovarian carcinoma, you go for a debulking surgery almost every day. Sometimes you give neoadjuvant chemotherapy and then go for a debulking surgery. Sometimes you just go for a debulking surgery and followed by chemotherapy. But in case of you see a ovary, very important thing is how much residual disease has been left after your particular debulking surgery, which decides the prognosis of the disease. Yes, so you can include that as well. I will just include that because these notes are going to be there for you for a long time. All right. So this is a very important prognostic factor. Correct. So histology of the tumor is very important. The clear cell tumors, how they are, or some lethal, Krukenberg tumor, which gets metastasized. All right. That's very, very lethal. You have another one, which is mucus or mucinous cell tumor. Serous is also bad, very bad, but it's got different grades. All right. So, but there are other much fears cancer. So definitely histology is very important. What else have you answered? Let me see. Yes, Mets, do the lymph nodes, definitely you can. So you have lots of answers. It's not any hard and fast rule. You have multiple answers. You can give those answers, and I would accept most of them. Correct. So these are multiple, what do I say, factors on which the this prognosis depends, and most of you are right in all the answers. So now, what's the most common route of spread of this pathology? This I would want to know. I remember teaching you this in my class. So yes, it's a direct spread. It's a direct spread. That's the worst thing, because you see the peritoneal deposits very fast, right? So it doesn't take much for the peritoneal spread, and then the spread to the remaining pelvic peritoneum, and then abdominal peritoneal cavity, correct? Yes, so it's direct, correct. So here are the answers. You get the answers, all you've already done before. Let me just add, though there was only 2, I'll just add this third point, that is the residual disease is very, very important. I just didn't want this part to residual disease, correct. Now, this was station number. Remember writing down your questions if you have any doubts, and we'll discuss it later. This is station number 3, in which what do you see over here? Here, see this. This is placenta. This is also placenta. Then what is this? What is this? And look at the hazy picture. I can hardly make out what exactly they're talking about over here. But then I thought first it's some cord prolapse or something they're talking about, but cord is right here. Then this placenta, here is also placenta. Then I understood this is subcenturiate lobe. Either they're talking about subcenturiate lobe or they're talking about this leash, which is very, very specific. What is that, guys? What is that? Let me see. Yes, excellent, guys. Do you need this class, huh? Do you really need this class? You already know the answers. This is vaza previa. Why do you call this vaza previa? What exactly is vaza previa? Can you just tell me that? Because that's okay, fine. That's okay. If you can just write down this is vaza previa, fine. But see, there are 2 types of vaza previa as well, but it's okay. That much is not needed for you. You can just tell me, just describe what you mean by vaza previa. Vaza previa. It's actually, okay, you keep answering, then I'll tell you the answer. You keep answering. The moment I get the right answer, I'll stop and I'll, okay, vessels, fine, vessels passing over the cervix. Which vessels? Which vessels are they? Why is vaza previa such a catastrophic condition? Why even 100 ml passing of this blood outside is considered catastrophic for the baby? I want to know this. Okay, great. I think I already got these 2 answers are there, which is very, very good. It's excellent. You got the answer. It's actually, guys, now remember, stop answering and listen to me carefully. They are not umbilical vessels. They are not placental vessels. They are fetal blood vessels, which is very, 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 very important. Okay, even 80 ml to 100 ml of blood loss if it is a vaza previa condition is catastrophic for the baby. The fetal heart will suddenly dip down and you'll have to rush for the emergency cesarean section. And if the patient keeps bleeding like this, or the baby keeps bleeding like that, by the time you take out the baby might not survive, because at a very early stage, at the stage of this, the fetal blood is in itself very less. Okay, so the total body might contain only some 400, 500 ml of blood. So even 100 ml, if it's lost, the baby can have so many problems, right? So you have to be very, very specific whether this blood loss is placental or is it fetal, because just in case it's fetal, before you take an action, it's already too late. Or before you understand, it's already too late. So this is actually a leash of fetal blood vessels which are communicating. This is a subcenturiate lobe. How many of you do not know the subcenturiate lobe? Please write down, for the sake of everyone, what exactly is a subcenturiate lobe of the placenta? Tell me that. Tell me that. You just it's a brief recapitulation for all of us. Since I'm already talking about it, might as well just make you guys remember, recapitulate, and quickly so that we can go on, jump on to the next, because I have a couple of slides coming up. And I think I have some 10, 12 slides to discuss tonight. And then there is another class coming. All right. So all your doubts in this next coming week, most welcome. Most welcome. Tonight, I was, because of my current schedule, I was planning to take up a smaller class. Yes. Cotyledon. See, I'll not call it a cotyledon. All right. I will not call it. It's a complete lobe. It's a complete lobe of placenta. All right. A complete lobe of placenta, which is communicating with the placenta, but not a part of it. All right. And how does it communicate? Because it's in the same membranes, right? When the placenta is delivered out and you see that one lobe is extra, you see that the membranes are attached to it. Sometimes the fetal blood vessels traverse from this place to the other place. So you can see that the major placenta is lying here. It's the one which is sending the umbilical cord to the fetus. And then these membranes, they are joining in with, and this actually the placenta is finished till here, right? Membranes keep going, they enclose the entire area till here. Both the place. So whenever the placenta comes out, the entire placenta comes out along with the succenturial lobe. And this succenturial is very important for the ultrasoundologist to inform the gynecologist that there is a succenturial lobe. Sometimes the placenta gets delivered out. This gets detached. It's just membranes, okay? They get just torn away and this stays inside. And we've seen the placenta, it's fine. It's okay. But the succenturial keeps, it's either it's attached or it doesn't come out and keeps causing bleeding. And some part of the placenta is still inside, right? So these things should be informed. These anomalies, not exactly, proper anomalies, but these variations should be informed to the gynecologist. This is a part of the ultrasoundologist's job. Anyways, so this is now some part of fetal blood vessels are here. So at the time the baby or the mother is having slight contractions, even Braxton Hicks, this can start bleeding. And we, in that case, will have to do everything in haste. I'll be informing you, teaching you this topic in the slides to come, so don't worry. Let's jump on to the next question. So this is a developmental anomaly of the placenta. You can see it's called as succenturial lobe, which you all have rightly said. What is a likely complication with which the patient might present? So the patient is going to come up with bleeding, fresh bleeding, along with maybe a fetal heart derangement. Remember that. So the moment the patient is bleeding and the fetal heart is also dipping down, be very, very super alert. This could be vaza previa, an undiagnosed vaza previa, which is not very good. Fourth question, what test is going to confirm the diagnosis? That I'm going to tell you when I'll teach you about vaza previa. And what will be the treatment? Again, that will also be taught when, but I really want to know, how many of you know this answer? What test is going to confirm the diagnosis? The fourth question. Okay. All right, okay. Yes, there is a diagnostic test. All right. Neelam, Geeta, can you please explain? Can you just elaborate APT for all of us? Previous with Doppler is what I'm going to tell you next. Yes. Please elaborate a little about APT for all of us. And 10% KOH with the, okay, fine. Maybe your examiners would want to hear that. It's more of theoretical benefit agreed towards it. Absolutely. I'll tell you exactly what the diagnosis is going to be for vaza previa. Okay, if the blood is fetal, it's going to turn green. All right. So this is for everybody who would want to give this as one of the tests, because the examiners, they have a very nasty habit of asking you, what if there is no ultrasound? How would you want to confirm? What else? This kind of question you can answer this. All right. So remember this, that there's an APT test in which the diagnosis can be done at a very clinical level, at a very basic level, that you might not need to involve another faculty in it. You can do it yourself, right? And a very, very basic test. Now, what will be the treatment for this condition? Can anybody tell me that? How will you, manage a patient who's having vaza previa? Yes, that's the answer. An immediate cesarean section. Correct. Agreed. Absolutely. So here, I'm just kind of elaborating it again. I've just written it down for everybody to just quickly go through whenever they're doing it. So you just go through 1 to 2nd, 3rd, 4th, points in the PPT, and they are there in your mind. So this is confirmed by something which is called as the color Doppler index, guys. Okay, this I want you all to know. This is according to the RCOG GTG. Nothing above that. All right. So vaza previa, there is a complete GTG. Okay, the Green Dot guidelines on vaza previa. So very, very important. Remember, guys, one thing I'd like to tell you, that if there is a Green Dot guideline, there's nothing above that, at least in RCOG, because that's only their recommendations, which are based on lots and lots of randomized controlled trials, meta-analysis, A++ grade evidence. So there is nothing above that. Otherwise, they do not use the recommendations. They don't say anything about recommended. They do not say anything until unless they are very, very sure of that. So when I say that this condition is confirmed through color Doppler index, that means, and this is a GTG guideline, remember that there's nothing above it. This is the confirmatory test. All right. But if the question is asked about what else, how can you do it in your labor room? How this is, suppose the patient comes to you bleeding. How well at that time you'll know, without the ultrasound, that this you can talk about your APT test, right? What else? The examiner have a habit of asking you, and they would want to know this APT, right? Okay. Now this is for all of you, just to make you more well versed with this vaza previa topic, because I wanted you to know a little bit in detail regarding vaza previa. So here, what I'm trying to say, I'm trying to impress upon you the fact is that the speed with which the fetal exsanguination can occur, it's very, very mortal. So you have to be very, very quick in deciding that this patient has to be taken up for immediate C-section. Otherwise, see, administration of corticosteroids for fetal lung maturity should be recommended from 32 weeks of gestation. You have to see what happens is that this vaza previa condition is usually already predetermined in patients who have been normal ANC patients for you right from the very beginning. Okay, in NHS or in UK, these people, they keep following up. Unlike in our country, there's some patients are coming, at the time of delivery. Some patients are coming at the time of, maybe towards the last trimester, and they have never followed up with you, and they're coming with bleeding. Sometimes they're coming with bleeding. So in that case, how do you know exactly which kind of bleeding is that? And the moment the patient is having bleeding along with fetal heart derangement, you can have a hunch, but you do not know for sure. At that time, getting an ultrasound on how difficult is it in a poorly resourced country, you understand that. So what happens usually in, in Western countries outside, they have been having those normal ANC routine patients. This color Doppler index usually finds out by 20 weeks, 24 weeks, 30, 32 weeks that this patient is having vaza previa. So such a patient is usually admitted. I've written it over here. See, a decision for prophylactic hospitalization from 30 to 32 weeks of gestation in women with confirmed vaza previa should be individualized and based on combination of factors including multiple pregnancy, antenatal bleeding, and threatened preterm labor should be given due care, correct? So over here, when I'm saying administration of corticosteroids for fetal lung maturity, this should be recommended from 32 weeks of gestation because they have a very high risk of preterm delivery. So you have to take it seriously. This we finished station 3, right?